So it's my privilege, and I'm very happy and honored to introduce our first speaker for today, who has been a teacher and mentor to almost all the dietitians. And I think she's one of the most experienced panelists today here. So it's an honor to introduce you, ma'am. So Miss Salome Benjamin, she's a registered dietitian and master trainer, CDE and TNT. She's a vice president and founder member of ADA, Association of Diabetes Educator, former chairperson, RDBO India from 2016 to 19. And she was also a president IDA Mumbai chapter from 2006 to 10. She's authored and published, presented papers and articles, reviewed chapters in books and journals. And she's known to everyone, I feel, here. So then I welcome you, ma'am, today for the first session. And over to you.
Thank you, Vandita, for those kind words. I'm grateful to Sukhada and IDA Mumbai chapter and all the participants, Hexagon and the Kenya Medical Center for having this learning series on for the participants with the other continents. And I'm privileged to be in your midst to share my presentation to begin this entire series on clinical nutrition and enteral nutrition. So my topic today is enteral nutrition, use it or lose it. So this is, we are going to take you through quick for 30 to 40 minutes about introducing the hexagon, introducing the enteral nutrition knowledge. And I hope all the participants here will take home the knowledge with them and use this very important therapy in the management of different clinical disorders in the hospital setting as well as the home setting. Next, am I sharing, Sukhada, or you are sharing? I have shared my screen.
We can see the screen. You've shared the screen, yeah. We can see the slides, ma'am.
So I am not able to take it next. Move it.
Maybe in a minute, perhaps.
Yeah. It's going ahead?
No, ma'am. Would you like me to share?
Okay, you share it. Otherwise, I stop sharing and you share.
Yeah.
Because it's not going ahead. So to begin with enteral nutrition, we all know enteral nutrition is the delivery of the nutrients via a tube and through the gut. So this is, can I have the next slide, please? So when we are not able to feed patient orally, or when the patients are not ready, able to accept oral feeds, we turn to this regime, that is the enteral nutrition, and we use the catheter or different French size tube to deliver the nutrition in order to keep up the nutritional status and bring the speedy recovery. Next, please. Yeah, so before we plan or before we want to intervene any therapy, we must have a algorithm. So if you have to decide what nutrition you are going to give to your patient and whether the gut is functioning or not, if gut is functioning, of course, we must use the gut and provide enteral nutrition. And we must keep re-evaluating frequently whether the gut function is improved or not. If the gut function is improved, we can continue EN. If gut function deteriorates, we can add to parenteral nutrition to the enteral nutrition. So if gut is functioning partially, also we use both enteral and parenteral nutrition together. And after re-evaluation, if your gut function deteriorates, then we decide whether to continue PN or EN. And if gut function is totally not functioning, then we keep providing parenteral nutrition, and we keep re-evaluating whether we need to change it. And if the function improves, because the gut is the largest organ and it does improve after providing nutrition, and if you give the rest to the gut. So partially we can transit it to the enteral nutrition when it starts working, and if not, then we can continue parental. So today's topic we are going to emphasize on enteral nutrition. Next, please. Next slide. Yeah. So the indications. So any therapy, when we want to start, we must look at the indication. So I have put indications in 4 different aspects. That is based on the ingestion, based on the adequate nutrition orally or inadequately, and also on the basis of the function and basis of the clinical disorders. So if we look at the ingestion, when the patient is not able to ingest with these disorders which are listed here, or a dysphagia, a neurological disorder, dysphagia due to this disorder, HIV, facial trauma, oral trauma, congenital abnormality, respiratory failure, cystic fibrosis, and traumatic brain injury, when we are not able to feed orally. So we take the enteral nutrition pathway. Then we come to the when there is inadequate intake, that is 1/3, less than 1/3 of the intake orally, we still have to provide nutrition through enteral nutrition, like hyperemesis of pregnancy. Many of times we are hesitant to give nutrition through enteral route to these pregnant women, but that is the right way to do when we are not meeting the requirement for burns patient, for comatose patient, for anorexia and congestive cardiac failure, cancer, COPD, and number of diseases when we are not able to supply adequate, that is less than 1/3 nutrition orally. Next, please. Next slide. Can I have the next slide, Sukada? Yeah, so as I was talking about, the other aspect is impaired digestion, absorption, and metabolism. When these function of gut is affected, like severe gastroparesis and diabetes mellitus or any other neurological disorders where the gut is not getting emptying, then we can use the enteral nutrition for inborn errors, for Crohn's disease, and for short bowel syndrome also, when the digestion and absorption is affected. The last one category is the severe wasting or depressed growth for children and with cystic fibrosis, for children with failure to thrive, and cancer, sepsis, cerebral palsy, and myasthenia gravis. These are the conditions where wasting is there and depressed growth is there. Next, please. I may go a little faster to keep up the timings list. There are different pathways which will tell us. Next, please. Next slide. What part of the gut we are using, what nutrition we want to use, whether it is for short term or whether it is for the long term. So when we say that we are using the gut, we are inserting the tube, and we already saw inadequate intake. It is just a diagrammatic way. And when we are using short term, so I will go straight away. When short term feeding, like 3 to 4 weeks or even less than 3 months, we can use a short term access. And when we need long term access, we can use long term access when more than 3 months or sometimes more than 6 weeks. So nasogastric route and nasoduodenal and nasojejunal route is used when for short term, and for long term we can have a surgical gastrostomy or jejunostomy. Next, please. Yeah, so I have already explained these routes, And this from the mouth, when you have an excess from the mouth to pass the tube, nasoenteric route it is called. In the stomach, it is called nasogastric. In the duodenum, that is the part of the your small intestine, the first part, duodenum, and then the jejunum. So these parts of the gut can be fed by using the different tubes and different procedures to give the food directly into this part when the patient is not able to take orally. Next, please. Yes, so I have already said short-term access is needed for less than 4 weeks, or sometimes even up to 3 months. We do keep this access for different conditions, underlying conditions like multiple fractures, skull fractures, and those who are sedated and paralyzed patient. These are oroenteric. These oroenteric tubes are sometimes not very comfortable, so we may not use it. We may directly use it in the stomach and the duodenum. Next, please. Next slide, please. To save the time, I would like little quick response. Whoever is handling my slides, thank you. Nasoorogastric tube. Yes, most common mode of enteral access is nasogastric or orogastric tube. It is simplest, not expensive, and it can be inserted at the bedside. And most of the countries, we have nurses doing this insertion of the tube. And these will have right from 8 to 12 or 14 French size. And this French size does matter. And we have a tube image here. And these are made of stiff polyvinyl material. And nowadays the technology is advanced, so we are able to place this tube in the part where we want to, so it is not displaced easily. And that's why when we are using a short term and a naso-oro route, we can use this tube very easily. Next, please. NG feeding, that is nasogastric. The few advantages and disadvantages, like I have already spoken, ease of tube replacement. Surgery is not required, very easy, and easy to check gastric residuals. Many times we use this nasogastric tube post-operatively for draining the stomach drains or any part of the drain. So it is also used for the residues. It is also advantageous and for the technically, and it is tolerated well, and you can use more hypertonic fluids. You can use higher feeding rates and the bolus technique for this nasogastric feeding. But the disadvantage here is it may increase the aspiration, and it may not be suitable for patients with compromised gut function, and may promote nasal necrosis if it is going to be staying there for a little longer time, or within 4 to 6 weeks, and the patient's quality life is affected. Next, please. Yeah, so another one after the gastric, it is the duodenal and jejunal route. And these tubes may be a little difficult to place, so we can use a city guided or a USG guided technique. And this route is for the people with gastric motility disorder, when the food is not passing through the stomach to the bowels easily, or delayed gastric emptying. Or with the GERD patients who have the reflex, nausea, vomiting, these these routes are better routes for them. And this can have a weighed or unweighed tip to keep the stylet in the place. And indications are those patients which have high risk of aspiration or high volume of GRV, we should prefer duodenal or jejunal route. And of course, when the gut function is compromised, that is stomach function. Next, please. Next slide. Yes, the long-term access one is the feeding ostomies. So we know about enterostomies, which are done through the bedside, like PEG, percutaneous endoscopy, enterostomy, directly in the stomach or directly in the jejunum with a percutaneous endoscope. And then there are surgical enterostomy, which are done either laparoscopically or with open laparotomy. And this also indicated when there is a impaired swallowing or cognition defect or any neoplastic disorders or cancer of esophagus and larynx. Next, please. Yes, this is called a stoma. A puncture hole is called a stoma or ostomy, and this is done very easily on the bedside of the patients, which is called percutaneous endoscopic gastrostomy. You can see the picture, you can see the placement of the tube, and it is very comfortable for the patient. Next, please. Yeah, the surgically done gastrostomy or jejunostomy, these procedures are done many times while the patient is already in the surgical room, and surgically the tube is placed into the stomach or into the jejunum. So this can be done by the surgeon whenever the indication is there that the patient is going to need it for a longer period, that is more than 3 months. Next, please. Next slide. Yeah, so jejunostomy is also similarly done. Commonly performed enterostomy can be used for who have had total gastrectomy, and when some surgeries we need to prepare the patients for the surgery. So while they are under preparation, elective surgery, the tube is jejunostomy is done so that we can continue feeding the patients, mainly for cancer of stomach or those who have atonic stomach where we cannot use the stomach. The food will be directly, nutrients will be delivered into jejunum. Next, please. Yeah, so now let's go over to the method of delivery of enteral nutrition. There are 4 different methods: the bolus, the continuous, the intermittent, and the cyclic. So to begin with bolus, most comfortable and most people use this method when you want to feed a large formula volume, like more than 250 ml over 10 to 20 minutes. And maybe say 6 times or 8 times a day, you can use the bolus method. And this is generally used for a gastric feeding when you are feeding in the stomach. And this requires an intake gag reflex. Now, gag reflex is something when we put the feed, it should not come out. So the patients who have a normal function of gut or don't have a paralysis, and these patients will have a gag reflex. And we can also check the gag reflex and use this route for the patients who can take it in the stomach through the bolus method. So ambulatory patients, you can do it for the sometimes, and you can put it off for the sometimes. And it is also associated with GI intolerance, abdominal pain, and cramping, nausea, vomiting. So when patients cannot tolerate these volumes, bolusly we go over to the next method. Next, please. So certain advantages is like it is a more physiologic. It gives a meal effect. Patient feels that they have eaten food, then the pump is not required. So it is very easy and inexpensive method, and also it limits the feeding time and mobility of the patient. And the disadvantages is little extra addition risk of the aspiration when we are putting a large volume in an empty stomach. And also the hypertonic, high fat, high fiber formula sometimes will delay the gastric emptying and patients may feel uncomfortable. So these are the disadvantages. Next, please. Yes, the intermittent feeding. So this is enter formula administered over a specific period of time. It can be through any time throughout the day. You can have a specific timetable, 8 a.m., 12 a.m., or 6 p.m. or 8 p.m. And 200 to 300 ml will be given over the 30 to 60 minutes, 4 times a day, which will precede and follow with the 30 ml or whatever you have the water allowance. You can put the flushing of the water. And when the patient does not tolerate bolus feeds, you can adopt this method, and this method goes also very well. And Initiation will not require any pump. You can use a gravity set and feed it, but you must have patience to hold the feed and let it pass through. Next slide, please. Yes, a few advantages. It may enhance quality of life. It may allow the mobility to the patients, greater mobility, more physiologic, and better tolerated. Also, disadvantages, it will also have a risk of aspiration because of the large volume. And sometimes there will be a gastric distension. The abdominal GERD might increase because you're feeding a large volume, and delayed gastric emptying. Next, please. Okay, the continuous method. This is mostly suitable when you are feeding outside the stomach, that is in duodenum, in jejunum, or later parts of the bowels. And this formula can be given continuously, either 16 hours or 24 hours. Usually via enteral feeding pump, it should be given, because then you can maintain the flow rate and regulate the feeding. So patients who cannot tolerate intermittent or bolus can be put. Patients who are having jejunostomy done, or having an nasojejunal tube, or post pyloric feeding should be given continuous feeding. Sometimes patients prefer patients will have the reflux and severe reflux when you cannot tolerate the other methods of feeding. And when there is a risk of aspiration, again, the continuous feeding is preferred. Next, please. So, next slide. Yeah, so among the disadvantage and advantage, it may improve tolerance, it may reduce the risk, increase the time for nutrient absorption, because the feed is going to come slowly and remain in the gut for a longer time. And the disadvantage is it is a 24 hours, so the mobility is affected, and it is expensive for home support, and very often you need a feeding pump to institute this method. Next, please. The cyclic feeding. So this is a continuous infusion of nutrients with a pump. You can do with pump alone over a 12 to 14 hours. Some people do for 16 hours also. Some people can do in 8 hours also. It is a very well-nourished, a very tolerated formula, especially for malnourished and ambulatory patients. When they are not ambulatory, they want to take the formula, they can take it any time of the day, mostly used for a nocturnal feeds, and very feasible way to feed the patients, for stable patients who are fed in the stomach or in the gastric. So if we look at the few feeding system, there are closed system, open system. Now closed system is something which is ready to use pre-filled formula, which you can just hang it for 24 to 48 hours, which does not require much of handling or contact. Thus, it reduces the microbial contamination, and it is very safe, but it is only thing is very expensive. But you cannot add anything into this formula. Whatever is there, directly you should be using it. Next, please. Next slide. The open system. This is a formula which is there, which is in a container, which you have to pour it into another container, or a feeding set, or a feeding reservoir, and you can ready to use it. The advantage of this formula is you can add a modular component like protein, fiber, or immunonutrition in this formula, and the hang time of this formula is 4 to 6 hours, and we have to see the label, and according to the instructions we can use it. So this is a better way. When you want to add additions to the formula, you can use it, but it can increase the risk of contamination, and therefore many institutions do not prefer it. But it is that you can make it a tailor-made for unstable patients. Next, please. Yeah, let's look at some gastric versus small bowel feeding. What happens when we do in feeding in the stomach or in small bowel? So yes, excess is very easy in the stomach, whereas small bowel you have to do either a USG or city guided access. And critically ill patient, gastric feeding may cause little intolerance when we do gastric feeding. And there is a risk of pulmonary aspiration, which causes pneumonia in gastric feeding, and which is a major cause of morbidity and mortality in ICU setting. That's why most patients in ICU, we prefer to give small bowel feeding. Next, please. Yeah, gastric feeding advantage, we have already seen. Just quickly to brush over, it's significant lower risk of infectious complication, improved wound healing, maintenance of the GI tract function, augmentation of cellular antioxidant system, decreased incidence of hyperglycemia when compared with parenteral nutrition, shorter length of hospital stay when compared with parenteral nutrition, more cost effective than, this is just a comparison with parenteral nutrition, and provision of nutrients in the gut results in a, of course, improved utilization of digested and absorbed nutrients. So better outcome. Next, please. Yeah, continuous versus other method. These are some level of studies which I want to tell you all, that based on the studies when they did 20 to 25 ml and 100 or 125 ml with bolus, continuous versus other methods, there was no difference in mortality, no difference in frequency of interrupted feeds or percentage goal feeds achieved or diarrhea between patients who received enteral feeds via continuous or other methods. So I think almost all methods are safe in regards to these factors. Next, please. Yes, gastrostomy versus nasogastric. Also, some studies were done. One level 2 studies for 24 hours post intubation, and early enteral feeding after intubation via percutaneous gastrostomy. So this had percutaneous gastrostomy had no effect when EN early was given. So early enteral feeding after intubation via percutaneous gastrostomy is associated with a significant decrease in ventilator associated pneumonia in critically ill patient. As we saw, this is a major cause of mortality in many of the ICUs. Therefore, we can choose the methods and we can also choose what feeding system we are using to prevent these mortality causes. Yes, next, please. Yes, early versus delayed. This is the most controversial topic, or whatever I see. We can have so many articles or research papers on this. But if I just conclude with 16 randomized control trials, it says within 24 to 48 hours, the enteral nutrition group with early and delayed nutrition, it is associated with a trend towards a reduction in mortality. So when we start early nutrition, it reduces the mortality in critical patients. When we start early nutrition, it will have a significant reduction in infectious complication. It's quite cumulative index is telling you the p-value is 0.02, and early nutrition when compared to delayed nutrition will have no effect on ICU or hospital length of stay. And when compared to delayed nutrition, it will also improve nutrition intake when we start early. So early nutrition is much better, and you must be emphasizing on giving early nutrition as early as 24 to 48 hours. In my about almost 50 years of practice, I've always imposed on even less than 12 hours for those stable patients. Next, please. Trophic versus, you all know about what is trophic feed, what is full feeds. What happens is sometimes when the trophic feed starts, it just goes on trophic feeds. We don't realize that we need to change trophic feeds to full feeds within a limited time, or when we already see that the patient is tolerating feeds. So the use of trophic feeds based on these studies had no effect on mortality, and use of trophic feeds also had no effect on ventilator associated pneumonia. Of course, the feed volume is so less, so it will not have. So therefore, both feeds are good, but only thing is we should not give trophic feeds for a longer time. It will compromise the nutrition intake and the outcome. Next, please. GRV, this is again a most discussed topic. I can talk for hours together on this topic, and we have guidelines, we have research stating that GRV of 500 ml versus 250 ml have no effect on mortality, infection, ICU, or length of stay. So we should not be worried about GRV. If it is 500, we should continue feeding. So not checking GRV again versus checking threshold also has no effect on mortality. Therefore, there is no mandate that we should check GRV for every patient. It is also not associated with any complications, GI complications. Therefore, GRV should not be given a lot of importance. Even if you are doing it, you may just do it routinely for whatever reason, but I think it is not mandatory. So there are enough documentation that we need not check GRV unless the surgeon wants it post-operative patients for some time, maybe 24 to 48 hours. Next, please. And the feeding should not be discontinued with GRV of 500. Yes, motility agents, we all are aware. Next, please. You can change the slide. This is what the prokinetics we are talking about, that it may be associated with an increase in gastric emptying, a reduction in feeding intolerance, and a greater caloric intake in critical ill patients. Therefore, it is suggested that we do give prokinetics or motility agents for patients who are having feeding intolerance. Next, please. pH, as the study says that compared to standard formula, the pH of the low pH does not have any particular clinical outcome. Therefore, you can use the standard formula for your patient. Next, please. I think I'm going to wind up. Next, please. Yes. How do we achieve target dose, and what is the importance of achieving target dose nutrition? Yes, it is very important to achieve the target dose of your macronutrients. And when we are comparing it to a slower rate of advancement or a delayed early nutrition in critically ill patients, early nutrition we have already seen in a target dose which reduce the mortality in critical patients. There will be reduction in hospital length of stay. There will be reduction in the number of infections and complication in head injury patients or almost all patients, and significant high calorie intake against versus lower calorie deficit. So most ICU we see a calorie deficit. So if you do not want the calorie deficit, you must achieve the target dose as early as possible. With use of prokinetics, you can do that. Next, please. Next slide. Yeah, the recommendation for delayed EN feeding. There are some contraindications or recommendation by the guidelines which says that the patients with high output intestinal fistula, if reliable feeding access distal to the fistula is not achievable, then you must wait and give delayed enteral feeding. With increased intra-abdominal pressure also, we must wait and not start early enteral nutrition. With abdominal compartment syndrome specifically, we must wait for GI function to come to normal. With overt bowel ischemia, when there is a lesser blood supply, also we must wait and not hurry to start feeding. With low dose EN, when acute, immediately life-threatening metabolic derangements are controlled with or without liver support. This is for liver or hepatobiliary system disease and patients with NKF. So there again, we can do a low dose and a delayed EN feeding. And of course, when GRV is more than 500, per 6 hour, that is 600 plus. Then we can start little later, delayed enteral nutrition. Next, please. Next slide. Yeah. So I think I am done with my presentation. Use the gut. Use it as early as possible, except for those contraindications. If we use it, we definitely improve the patient's outcome. We control the infections, we control the complications, and most important is the bacterial translocation, which happens when the gut is not fed. So we should not allow that, and that is one reason patient has complications. So we must use it early, and you must use it at the target dose. We must use the proper method, and we must also be very careful to use as different tubes, French size. You will need a different types of feeding. I think my next speaker will take those topics, that how you can tighter your feeding, or which system you will use with which French size tube you are using. So thank you very much. Next, please.